All right, here we go. A lot of definitions, just things to add into your musculoskeletal and trauma vocabulary. Things like sprains, contusions, dislocations. They're just definitions, that's all. And you've heard these terms before. Now, when people get traumatized and sustain trauma, there's a couple things that you got to worry about and think about as a nurse caring for these people. One of the first things is neurovascular compromise. And basically, what this means in a nutshell is at the site of injury, is there any problem with the delivery of nerves and blood flow and nutrients distal to the site of injury? So think about an injury that's, say, in the middle of the leg. If there's neurovascular compromise distal to that site of injury, you may have numbness and tingling distal to the site of injury. You may have reduced blood flow. And you can assess for these things, and you will be assessing for these things. Compartment syndrome is very interesting. When people sustain an injury, and I always use leg injury as the easiest sign because it has very well-defined compartments with fascia containing each of the muscle groups. If people sustain something such as a crushing leg injury, there's going to be inflammation, there's going to be edema that develops, and that fascia isn't really stretchy. There isn't elasticity to fascia. So just like the skull, think of it as a closed compartment that can only contain so much inflammatory fluid. If the pressure within that compartment builds up, the pressure could push on a blood vessel and close it. If it's a vein, it's closing off blood flow back to the heart. If it's an artery, it is closing off blood flow distal to the site of injury. One of the signs of compartment syndrome are changes to neurovascular integrity. Hey, look, I'm not going to waste your time and read every definition of fracture here on this page, but they are very interesting. Take some time, read through them yourself, get comfortable with some of the terms. I will tell you one of the ones I find most interesting is the avulsion fracture, where the bone breaks in such a way that the tendon attachment on the broken part actually pulls the bone away and makes the fracture worse. The other one I'll make specific mention to here is the pathologic fracture, because sometimes people muddy up what that's all about. In a pathologic fracture, some other disease process caused the breaking of the bone. Cancer that is metastatic to bones may be a source of pathologic fractures. Osteoporosis may be a source of pathologic fractures. Multiple myeloma with disease in the bone and lytic lesions may produce pathologic fractures. Matter of fact, multiple myeloma is often diagnosed when a pathologic fracture occurs. Now, I realize it's a pathophysiology class. I don't focus much on treatments because that tends to be more of a med-surg thing, but I do like to, whenever I'm doing a musculoskeletal talk, just talk about the acronyms such as ORIF, open reduction and internal fixation, which is a very common way to secure and help heal fractures. These terms refer to where the break occurred, and you got to think about this in some way. Wherever there's a fracture, there's a space between two bone pieces or more. So the idea of reducing the space, that's what reduction means, is to facilitate healing. Then the idea of fixating, either internally with hardware or externally, is after you've reduced that space, fixing those bones in place to again facilitate better healing. One of the interesting complications to musculoskeletal trauma and fracture specifically is the potential release of fat within the marrow into the bloodstream. It's called fat embolization syndrome. Now let's back up a quick second and define what an emboli is, or an embolus. An embolus is anything kind of floating within the bloodstream that has the potential to occlude blood flow at some point within the vasculature. In this case, we're talking about fat, a bundle of fat, occluding blood flow within the vasculature. In a second, we'll talk about a thrombus, essentially causing the same thing. Air can sometimes act as an embolus, and you can get air emboli within the vasculature. Fat embolization syndrome is exactly as the name describes. After a fracture, fat from the marrow enters into the bloodstream and potentially causes a vascular occlusion somewhere downstream. And when I say vascular occlusion, I mean then the fat blocks blood flow distal to the site where it got lodged. This slide is just kind of a one-slide summary of complications that you as a nurse may see when working with patients that have trauma, musculoskeletal trauma. So we mentioned neurovascular compromise, compartment syndrome, fat embolization. Is there the potential for infection? Heck yeah, absolutely, especially if the trauma produced an open lesion whereby microorganisms may enter. Could it produce deep vein thrombosis and pulmonary emboli? Absolutely, and that's something that you will monitor for clinically, and a bigger explanation on that is coming up. Whenever patients have deep vein thrombi, and the potential for pulmonary emboli, you'll hear clinically the reference to something called Virchow's triad. I'll admit right now, the correct pronunciation is Virchow. But there's a CH, so I just have to say Virchow, I'm sorry. And what Virchow's triad indicates are three components that contributes to the development of deep vein thrombosis. And those components are injury to the vessel wall, venous stasis, or slowing of venous blood, and hypercoagulability, increased blood viscosity, as might be found in cancer syndromes. Those are known to create hyperviscous blood. Supplemental estrogen is known to increase blood viscosity and predispose to blood clots. And cigarette smoking. Here we have a wealth of information on deep vein thrombi, or DVT. DVT is something you will spend your clinical life looking out for and trying to prevent, because the complications of DVT are multiple. But essentially, deep vein thrombosis is a blood clot within the venous vasculature, and they most often occur in the leg veins. Doesn't mean they can't happen in the arms, just most common in the legs. The most serious complication of a deep vein thrombosis is if that thrombus breaks off from the leg veins, travels up the venous vasculature to the right side of the heart. You got to follow your cardiac and cardiovascular A&P here. To the right side of the heart, and then gets pushed up into the lung vasculature, where that clot can, just like a fat embolus, occlude blood flow to a portion of the lungs. Depending on the size of the clot, the occlusion could be minuscule or it could be massive. Just like myocardial infarctions, small pulmonary emboli can be relatively asymptomatic. Large pulmonary emboli can be deadly. Now, don't think that trauma is the only thing that puts a patient at risk for the development of a deep vein thrombus. As we mentioned just a few minutes ago, within Virchow's triad, there's lots of pathologic conditions that increase the risk for DVT. That being said, what are you going to look for clinically? Well, there are some outward signs, such as redness of a particular vein, some warmth, indicative of inflammation at that site. There's an assessment tool called Homan sign, which includes passive dorsiflexion of the foot in an attempt to elicit pain in a leg that has a clot in it. I will mention to you that Homan sign is not positive in every case of DVT, but it still is something that's in regular clinical practice, because if it is positive, that does raise the clinician's suspicion that a DVT has occurred. Ultimately, your clinical assessment is going to raise or lower your suspicion of DVT, but it's going to then lead your patient to some type of imaging to show that a clot is there. Ultrasound is the most common tool, and the interesting thing about ultrasounds and DVTs is that the stability of the DVT can be pretty well guessed at. And what I mean by stability is how likely that clot is to stay affixed to the leg vein wall versus how likely that clot is to break off and become an embolus that could eventually end up in the lungs. A newer clot is considered unstable and has a higher potential for embolization. An older clot, however, is considered to be much more stable and reduce the risk for pulmonary embolus potential. Treatment for DVTs include blood thinning agents, but patients are given those blood thinning agents just so that the blood viscosity does not traumatize the clot within the legs. Patients are only on blood thinning agents until a new clot has solidified into the vein wall enough where the risk for PE or pulmonary embolus is low enough that blood thinning medication can then be stopped. Avascular necrosis. The name kind of says it all. The loss of vascularity to bone and subsequent development of necrosis of that bone. The acetabulum is the most common site. What causes avascular necrosis? Well, it could be a whole bunch of different things. Could be stress. Could be disseminated intravascular coagulation, the formation of clots throughout the body. There could be a specific embolus that was sent there from another part of the body, or just vascular occlusion or vascular loss over time through arterial disease. Avascular necrosis does need to be treated surgically, and one of the things that you may see clinically is the grafting of healthy bone tissue to the necrotic area. Volkmann's contracture is actually an elbow phenomenon, with clinical manifestations making it look as if it's a hand phenomenon. Isn't that interesting? So in Volkmann's contracture, swelling within the antecubital area up here, or some kind of compromise to the brachial artery, produces vascular hypoxic changes that make the hand essentially start to contract this way. Pelvic fractures can be a big deal. When you're thinking about pelvic fractures, there's two general categories that I want you to think about: stable pelvic fractures and unstable pelvic fractures. The unstable ones allow for pelvic movement that really make the ability to heal compromised. Down below, I have three of them: rotationally unstable fractures, vertically unstable fractures, and then fractures that involve connection to the hip joint, such as an undisplaced acetabular fracture. These fractures encompass what would be collectively be called the unstable pelvic fractures. These patients will probably be immobilized and will be at very high risk for DVT while they are healing. No chat on musculoskeletal trauma would be complete without talking about bed sores, whose better clinical name is pressure ulcers. Think about the patient with the unstable pelvic fracture who is forced to lay in bed for a prolonged period of time. This is a huge risk for bed sores, especially in older people whose sensory nerve input to turn and get off areas of pressure are not perhaps as intact as they used to be. One of the most basic nursing interventions that we do as nurses is turning our patients every 2 hours to prevent the development of bed sores. Bed sore pathology is fairly easy to understand. It just involves pressure at a certain site and then the loss of adequate blood flow to that tissue. That tissue then becomes necrotic. Bed sores come in many stages, and you will see innumerable amounts of pressure ulcers within your clinical life. This is the classic pathology wherein prevention is the best medicine. In patients who sustain amputations for whatever reason, maybe they've been diabetic, maybe they were in some kind of traumatic incident, they've lost a limb, there is this phenomenon, this complication to amputation called phantom limb pain. And it has been studied over and over and over again for years and years and years. There is still really no consensus with regard to exactly what creates or manifests or constructs phantom limb pain in a patient's mind. But definitely, we know clinically this occurs. The reason I bring it to your attention here is because phantom limb pain has been intervened upon with things such as mirror box therapy and now with things such as virtual reality. And phantom limb pain represents one of those clinical phenomena that I think are really interesting, whereby we're intervening and I think succeeding in some capacity, even when we don't necessarily know the underlying pathology of the phenomenon that we're intervening upon. Feels a little bit like the cart before the horse, doesn't it? But in this setting, that's okay. Okay, musculoskeletal disorders, musculoskeletal trauma. Did it feel like a lot of words? Did it feel like a lot of vocabulary? That's usually what I find when I talk to students. It's just a lot of terms and terminology. For some people, that's good. For some people, they go, whoa, I'm term overwhelmed. I get it. But just really a matter of acclimating yourself to these terms so that when you read them in a chart, you know what's going on with your patients. Or you hear these terms clinically and you know what's going on with your patients. What kind of fracture they had. What compartment syndrome indicates. Who's at risk, or what parts of the body are at risk for pressure ulcers. And why do we reposition patients in certain poses to reduce that risk? Who's at risk for DVT? Where is that risk presented?